Thank you. So I think I'm the obligate healthcare provider in the healthcare track, right? So a little bit of a background. As I was introduced, I am a physician. My specialties are critical care and pulmonary medicine. I spend about half my time doing patient care, so I was asked this earlier. So last week I was attending in the ICU. And the rest of the time I get to play with a group that works with me on developing a technology platform where we've used the WSO2 stack, and I'll introduce that a little bit in today's talk. So a little bit about the Cleveland Clinic health system and the hospital. I don't know if you can see this from up here, but this is the Cleveland Clinic main campus. It's of course in Cleveland, Ohio. It's consistently ranked in the top 5 hospitals by U.S. and World News. For cardiac care, it has, for the past 18 years, has been the #1 hospital in the country. We are both an outpatient clinic and an inpatient facility. We see about 5.5 million visits every year. Last year, there were about 160,000 admissions and a fair number of outpatients or procedures. The number of physicians, it is an employed practice model, so every physician is employed by the Cleveland Clinic health system. That number is probably up to 4,000 now. So in addition to the main campus, we have several community hospitals and some family practice centers. So in Northeast Ohio, there are 8 other hospitals in addition to the Cleveland Clinic. What's not on the map is that we also have a hospital in Florida, in Weston. It's about 160-bed hospital. And there is a new facility being constructed in Abu Dhabi, which, like all constructions from the Middle East, is a massive construction project, and it will be the CCF Abu Dhabi, which will open next year. So, the premise of what I'm talking about today, I think it has been addressed a little bit in the talk yesterday on healthcare. This was under President Clinton. The Institute of Medicine had this report out, and it sort of shook up the world of medicine a little bit, ended up creating a lot of editorials and rebuttals. But it is a fact now, and it is well recognized that healthcare is an error-prone industry. If you go into a hospital, there's a good chance that there may be something that will go wrong. The estimate is that about 50,000 to 80,000 deaths every year are caused by errors in medicine. Right? So, in addition to that morbidity and mortality of errors, there's also a financial cost. So, there's a financial cost on top of the healthcare, the human cost, and that's estimated to be around 17 to 30 billion dollars, billion with the B, I should say, every year. So errors are extremely costly, and early on in my career as a physician, just out of training, I trained up on the East Coast, it was apparent to me that a big chunk of these so-called errors are really a data problem, and so we'll talk about that a little bit today. So this is from the National Patient Safety Foundation. This is based on a survey, and the numbers are consistent in many studies. The vast majority of these errors fall into those top 2 categories, right? They are errors of diagnosis and they are medication errors. That account for about 70% of errors in medicine. So errors of diagnosis are when you apply the wrong diagnosis or you miss the diagnosis, right? The correct diagnosis is not applied in a timely manner. And oftentimes it's because either the providers don't have the data. So a chest X-ray was done, there was a new finding, but I didn't have it on time when I was seeing the patient, and therefore it's a data availability problem. And at times it is an analytical issue, right? There was a data X-ray yesterday with an abnormal finding. The patient has a poor immune status and has a low-grade fever. I should consider pneumonia, but I didn't put all of that together at the right time. I didn't put that diagnosis on, and therefore it's a misdiagnosis. So you can look at misdiagnosis, the vast majority of them, as either a data availability problem or a data analytical problem. Medication errors are often the wrong medication, right? Or this patient shouldn't have had the medicine given because he has either an allergy, another medical condition, or a drug interaction. So here's a great example. I mean, this is very fresh in our minds, right? So a patient presents to an ED, and he tells the provider there, I just got back, I'm listening from Sierra Leone, right? And I'm not feeling well. So you would think that if the entire planet was occupied with an existential crisis, that alarms would ring and a SWAT team would descend on this patient and they would put him in isolation, right? No. What did they do? They said, go home, take a couple of aspirins, so it's going to feel not feeling well, right? Now, not to beat up on this hospital, I've worked in 4 different geographic areas in this country, and I can tell you that the vast majority of EDs, that's probably what would happen, right? Now, the data was there, but it probably wasn't available to the right providers. The physicians did not probably have access to that data. It was probably not flagged appropriately. So there was a lot of blame going on back and forth. It's probably even an analytical issue, right? I mean, you could say list of countries travel, fever, blah, blah, blah. It's a simple rule. It's not complicated. So not only does patient go home, right, and then eventually expire, but also there was that time period during which he was exposed to others. So now there's a tremendous cost of the system to contain, identify, and quarantine this patient. So you can see that errors are at the end of one, it causes severe morbidity to or mortality, but there's also a widespread healthcare cost issue. Now, errors are important, and I'm glad that medicine is sort of focusing its interest on errors and preventable errors. But I think what gets missed in that discussion is what are the opportunities that are out there. If we could use all the tools that are available to sort of integrate, filter, sort, analyze data, and create new knowledge and new value from this data, what would we do differently? What are the new things that we can do with this sort of healthcare data? And I know there are some question marks out there on the slide, but I have to tell you that we are actually starting to do some of this within healthcare using data. So can we use, for example, and these are exemplary questions, can you use clinical data and find patients? Now, the flu season is coming upon the Northeast, and our units are going to get full, and we are not going to have enough beds. So can we find patients who are appropriate to transition to a low level of care, right? Can we use the financial data and redesign care so that we can have compatible outcomes but use a cheaper modality? Do we have to get a CT scan in this instance? So it is decision support at the end of the line. Operational data and sort of changing how and where care occurs using data as a driving mechanism. We're starting to get into benchmarks. The hard thing with benchmarks is that clinical outcomes and clinical variables are very, very hard to compare. If I give you 2 hospitals and say, pick the patients who were admitted with an acute myocardial infarction and tell me how many days they stayed and what the cost was. It's incredibly hard because everybody has their own way of describing the condition, the medications that they use, the treatment protocols, and the outcomes. But as we start to aggregate data and we develop the tools to be able to look at the sort of data, we can actually start to compare outcomes and costs across different healthcare entities and providers for that matter. Population health is getting to be a huge thing. Accountable care organizations has changed how we pay for care. So now ACOs are responsible for large groups of patients, right? And it's a prospective payment system. So you have to somehow measure the health of a population. You have to be able to measure it as time goes along. You have to be able to identify risk factors that put a population at risk. And then when you intervene and start to change these behaviors, you have to again remeasure and see if you're headed in the right direction or not. It is clearly a big data problem, and it's right within the scope of what we can do with data analytics. And as we start to protocolize medicine, what we don't know is, are we guaranteed success, and will costs go up, go down, and will the outcomes be acceptable and compared to what we have now? So why is this hard in medicine? Well, right on the left-hand top corner, it's a people-oriented business, right? It's all about people. There are patients, and then there are people who take care of them. And it is also a highly, I have resident fellows who train, nurses come and go. It is incredibly hard because variability is built into the paradigm. As soon as you have a bunch of people, you can get out a bunch of other people. And the processes are fragmented. So the ED example that I gave you of the patient with Ebola is a good example. The processes are highly fragmented, and it is really, really hard when there are all these manual processes to get some consistency. and an improvement in how we do things. And the electronic medical record, I know it has come up in this discussion several times. These are legacy systems. I don't know if anybody here knows what the MUMS language is. It's for the Massachusetts General Hospital Utility Programming System. That's the language. That's a system that underlies most of the systems out there, electronic medical record systems out there. So these were not built for data aggregation or data analytics. So here's a bit of an overview of the platform that we built. It's really sort of first as a data integration and a data storage platform that enables on the right hand of a corner sort of this query and analytical engine that we built. So I'll start from that end because that was our history. We have this analytical engine that we had built that would allow, you don't have to be a fighter pilot to drive it, a non-data scientist clinician, an average clinician could, using close to clinical language, a clinical query language, compose a query, right? If who is here, who has had fever and a normal chest X-ray, a high white cell count, these are all things that make up, let's say, a pneumonia that has been acquired in the hospital. It's easy to compose that, in real time find out who the patients are that match that, go back in history and say, in the past month, who were the patients, be able to look at the patients and say, okay, do I have the right query? Am I missing patients who should be on this list? Am I picking up patients who should not be on this list? Refine that query, and then when you're satisfied, deploy that so that in real time you can pick up these patients. How complex are these criteria? On an average, about 30, 40 criteria. Some are bigger, some are extremely small, some are just simple criteria, right? So in order to make this happen, what we had to build was a data aggregation engine that was extensible and scalable. And as you can see on the bottom end, a lot of the data uses the HL7 standard. Now when I say standard, I mean that not very seriously. HL7 is not really a standard. It is very poorly implemented. Even within the walls of a healthcare entity, we have different flavors and different implementations, so it is not really plug and play. And the healthcare vocabulary adds another layer of complexity on top of the complexity of HL7. In addition to HL7, we have some other traditional data integrations. Some things are pulled in by batch ETL processes. We do integrate with some proprietary databases, so there are some other ways of pulling data in. Our storage is Cassandra. We brought on Cassandra and put all of this into a standalone Cassandra. And so the architecture really is the WSO2 ESB and the data services server. And we have a very rich metadata management program that injects metadata into this data as it comes in, because in healthcare, you can take one test, and what is important is where was it done? Was it outpatient? Was it inpatient? Was it in the ED? When was it done? Was it at admission? So all of this metadata becomes extremely important if you are going to run any analytics on it. So we inject that into the data as it comes in. And then the customers actually access through a bunch of UIs that we've created that supports things like our electronic hospital monitoring initiative, our compliance and clinical compliance programs, care packs, which are clinical protocols, case management, throughput management, and so on. So this is a WSO2 stack that we use, the ESB, the CEP, and the data services server, and each one of them is deployed in a high availability mode. So the ESB and the DSS will be running a hardware load balancer. That's sort of our technology architecture, and the CEP uses its Hazelcast high availability mode. So sort of this block diagram, each component is clustered, highly available, failure tolerant. So we have integration, which is WSO2 based. We use again WSO2 and CEP for the technical monitoring of the stack, and the analytics is our internally developed application, which is also clustered with itself. But storage is actually an interesting paradigm because people ask what database do you use, and the answer is well, we use one database because one storage paradigm doesn't fit all of it, right? So metadata fits very nicely into a schema-enforced relational database paradigm. Whereas, if you are getting a bunch of data that you need to put in very quickly and eventually consistent model is fine, then Cassandra works really well for that. And then we are forced to get data from a bunch of other proprietary data sources. So how do you make all this work without pulling your hair out? And I think the DSS works very well in this situation. It's been incredibly simple to expose a lot of these as web services using DSS on top of it and then consume that through the DSS. So I think perhaps in all the noise around the ESP, the DSS doesn't get the credit that it deserves. At the time that we were looking at the stack, we did run into some problems with the WSO2 message broker. I know those have been fixed. We had some prior experience with ActiveMQ, so the WSO2 ESP is backed by an ActiveMQ message broker, and that allows us to throttle, because healthcare data is sort of irregular in how it comes to us. So just before 7 o'clock in the morning, before nurses leave for their shift, they get on the EMR and put a bunch of data in there, and so we get posted with a lot of data, and we need to process that really quickly. So we need to have some sort of throttling, or we could really get into trouble. So monitoring, I think this is this became apparent to us that it was going to be harder than what we thought it would be. Healthcare at all levels is a big data federation business, right? Because when we get data from the EMR, or the EMR itself is getting data from a bunch of vital signs and a bunch of people putting data in. Now, like Groove, Epic and others are going in and integrating data from consumer devices, or through health, or mobile health platforms like HealthSpot, which allows people to go to. So any of this may break at any time. So it is not important to just monitor the fact that data feeds are coming in. You need to know what kind of data is coming in and are they all appropriate. So you need a level of functional monitoring. You need to peek into the data and make sure that this is all right. It is not uncommon for you to get vital signs from 2 different machines for the same patient, apparently, because they've been registered erroneously to 2 machines. So you need to be able to pick up all of these, build in rules, and filter them out as appropriate. So this is our functional monitoring. We're actually looking at the data within these streams in real time. This is a 15-minute view, and it sort of builds a graph with Gangnam, which is our visualization layer. And it's worked pretty well. This feeds Xenos on the back end so that we can get notification when things go down. So in effect, what we've done is built a unified platform that allows us to sort of measure our processes and also improve our processes simultaneously using data and analytics as sort of as a backbone. I'll quickly run through a few case scenarios. We've improved our physician documentation. This is our metric. This is how we get paid. It is a huge financial gap when hospitals don't document all the care that they provide. We've actually improved some of the documentation gaps by over 100% just by using the Today in Florida, they actually manage some of their critical care unit bed assignments and throughput using data analytics and identify patients who are stable and ready to be moved out to a lower level of care. This was a great and extremely satisfying project to work on. If you have somebody in the hospital admitted for, let's say, a very critical illness, we all know that physical therapy and occupational therapy and rehab actually makes them better. We have data now in the literature that it shortens the duration of care and improves their functional outcome. Yet, even at the best hospitals, how patients are picked up and put through rehab and physical therapy is highly variable, right? And it is because it's a moving target. Patients are not identified in a timely manner, and scarce resources for rehab are not applied in a timely manner. However, you can think of it as purely a data problem, right? If all the vital signs are stable, or all the labs are within normal parameters, and the patient is getting better, there is no reason why you cannot provide a list to our rehab people. So we did this in our ICU, and there was a dramatic improvement in the functional outcome of patients where we intervened compared to the units where we did not. So I think these are sort of great pilot cases where data-driven protocols and healthcare delivery can actually improve outcomes. and change the course of care at actually less cost. So I think a lot of this has been alluded to also when David. It was a very quick way for us to get into it. The Carbon pluggable component architecture is great. It allows our developers to transition their skills that they learn on one platform to another very quickly and very easily. It was really a zero code implementation for us to get HL7 integration in place. Everything was in XSLT. My programmers who had worked on other platforms couldn't believe it that they had done so much work in not writing a line of code. As I said, the DSS is a great data access layer in a box. And if you're dealing with multiple data sources and managing them, then it's a great way to go. And of course, we use CEP for the sort of functional monitoring of our platform. That's it. I'll end right there and take any questions. Yes.
How long did it take to implement?
So much shorter than what our IT department was used to. In fact, the census, hospital census, somebody talked about a master patient list. Building a patient census, by the time we had everything together, within 2 weeks we had a census taken. So we knew who was where, and it's called an AED system, admission, discharge, and transfer. That was built in 2 weeks. So that was pretty fast. Most of the platform was done in about 4 months. We have integrated all those hospitals, and so it is a big challenge. There's quite a bit of variability. So it took us about 4 months to have the stack going, where we had usable data and visualization.
Who is your EMR vendor and are they integrated? Okay.
And yeah, we pull data from Epic. The HL7 interfaces that are coming to us are all from Epic.
What are some of the challenges that you face specific to technology?
I think if you ask about challenges in healthcare, I think it is really the data itself and the HL7 implementation. It's highly variable. It is post-processing at every component. The vocabulary itself is really hard. So take our healthcare system, for example, right? If you want to capture one thing like urine output, right, there are 200 ways of it that I described it. 200 ways. Pre-op, intra-op, post-op, catheter, urinary, pediatric. Because the data was not created with a view to aggregating and monitoring it. So you that process of normalizing the data and things which are expected to be numbers will occasionally give you a full text comment, and this could not be counted because you have to deal with all those uncertainties and how to get it. That was really the challenge. The rest of it, were things that we could easily work around.
Are you using the WSO2 test?
Yeah, so HL7 support for WSO2 is built using the HAPI library, the HAPI library, and the HL7 API. So what WSO2 has done is really sort of build it inside of their DSP. So it gives you a great way to get HL7 and quickly cast it in the XML and deal with the XML representation of HL7. There are some nuances within how you handle that, and you've had to patch a few things, and there was some talk about it, and I think that support is getting better. But all the instrumentation that WSO2 comes with, the ability to monitor things that go through DNS, counters and so on, that's what really makes it so much easier to build the study quickly. Because it's one thing to build it, another thing to monitor it and troubleshoot it and find problems with it.
In our presentation, you have everything related to HL7. I have not seen the EDA go on the clear messages.
We don't do it yet. This is a clinical decision support tool, so we don't do that.
But in the CRE architecture, you also had op nodes and problem lists as well as sources.
Yeah.
Was that HL7 or CC?
HL7. There's no reason why you couldn't deal with CCD. I mean, given the schema is easy enough to put the data in. And in any case, as soon as WSO2 gives you HL7, it's already in an XML format. So.
And the HL7, the messages themselves, how were they contributed to this platform? Was it 5 days, or was it 5 days, or was it a web service call posting HL7 message?
So if you look at HL7 specification, the 7 steps for the 7th layer of the stack, right? So most of 807 is built on the NLP network, so good. And most hospital systems will implement a 807 multiplexer, one of these commercial. So we get the 807 messages from one of those commercial 807 systems. Thank you.
Thanks, Bobby.